Hey everyone, welcome to the Module 6 exam review video. My name is Justin and I am the EMT instructor at Baton Rouge. This video is part 1 of 3 and will primarily cover the highlights of Chapter 15, Shock and Resuscitation. I want to preface that this week's module is very large, containing a lot of information across 6 chapters. We often call this set of chapters Medical Emergencies 1, and the exam will introduce even more scenario-based questions than you have seen in the previous exams. Since we have a lot to cover, let's go ahead and get started, and remember that you can pause or rewind the video at any time. So we first need to start by defining what is shock. And to do that, we need to recall the term perfusion, which is the adequate delivery of oxygen and nutrients to the cells as well as the removal of waste. And shock is simply known as hypoperfusion or inadequate tissue perfusion. Whenever we have a disruption for the components necessary for adequate perfusion, your patient is now at risk of going into a state of shock. And these issues are usually caused due to inadequate volume, inadequate pump function, and inadequate vessel tone. Inadequate volume is probably the most common etiology of shock, and this is when you have a decrease in blood volume. So just imagine your patients that are severely dehydrated or they've suffered some trauma and they're bleeding out everywhere. If you don't have enough blood to deliver your nutrients and oxygen, then that is going to lead to hypoperfusion. Probably come up with more obvious examples of loss of volume, but just remember to do a patient assessment and make sure you take a thorough history to rule out any other causes for loss of volume, such as frequent urination or even excessive diarrhea for the past few days. Next etiology we'll cover is inadequate pump function. And this one is as straightforward as it can be, right? If your pump is not working, then you are not delivering nutrients, you're not delivering blood, and you're definitely not removing any waste from the body. Most common examples of inadequate pump function is a heart attack, otherwise known as myocardial infarct. You all should be able to break up that term myocardial infarct as death of heart muscle, and plainly put, if the heart muscle is dying or is not working, then that will lead to the pump failing. A couple other examples we'll highlight here is the pericardial tamponade and the tension pneumothorax. We'll probably talk more on these later in the cardiac and respiratory chapters, but for now, these are just a couple extra examples. And so the last etiology of shock we'll cover is inadequate vessel tone. And this relates more so to the vessel size due to massive vasodilation. And what you have to understand is as the blood vessel vasodilates to the point where the systemic vascular resistance decreases too much, you're now going to have a drop in blood pressure. Try to recall from Module 2 in your A&P chapters where we discussed that an increase in blood pressure generally means that you have improved or better perfusion, whereas a drop in blood pressure means inadequate perfusion or inadequate blood pressure. And so that's why we always mark that 90 systolic as our cutoff for what is considered, too low. This slide is just to kind of give you guys a visual representation of how vasodilation or massive vasodilation will lead to a decrease in blood pressure, right? So a normal sized blood vessel is full of blood. You have enough systemic vascular resistance to generate an adequate blood pressure. And when that vessel gets way too large, you just don't have enough volume to fill all that space. And that's going to decrease the resistance, therefore leading to hypoperfusion or shock. So next we're going to cover the 4 major categories of shock, and that's going to include hypovolemic, distributive, cardiogenic, and obstructive. Some texts like to list a 5th category when the metabolic and respiratory shock. For the purpose of this exam and what we usually talk about in class, we tend to leave out that 5th category, but if you want to review it later for your final exam or for the NREMT exam, I'm going to talk about it a little bit too as we progress through the slides. For the purpose of this exam, you do need to be very familiar with the four categories of shock, and we should be able to provide examples for each. So hypovolemic shock is probably the most common type of shock out there, and it is also most commonly caused by hemorrhagic shock or the loss of blood. We have a few other examples like burns and dehydration that can cause low blood volume, but just remember that hypovolemic, you're thinking about a loss of volume. I want to stress that it is due to a loss of volume because I think some students get trapped into thinking that it's only blood loss. But hemorrhagic shock is just, one specific type of hypovolemic shock. Um, we have to consider other examples where a patient is either not getting enough fluid intake or they're losing fluids by other means. And so that will fall into the category of non-hemorrhagic shock or non-hemorrhagic hypovolemia. Getting a little redundant here, but this is hemorrhagic hypovolemic shock. And again, this is due to a loss of whole blood. As a result, you're going to have decreased perfusion and decreased oxygen carrying capacity. So, best way to manage this is for one, stop the bleed. Remember that we treat those bright red splurting bleeds, with direct pressure. And if it doesn't work, we slap on a tourniquet. Outside your scope, but maybe in the hospital, they could replace blood or start replacing blood components. And all that is to hopefully uh, bring back some function of what was lost. So another example of hypovolemic shock is burn shock, and I think a lot of students don't take enough perspective into how much burns affect your fluid retention. We have to remember that your skin plays a major role in regulating fluid retention in the body, and so if you have enough burns across a wide enough body surface area, um, your patient is now at risk of losing fluids. Beyond that, your capillaries, when they become damaged from the burns, will become more permeable. And what that means is that you're going to start leaking these plasma proteins or your plasma into the interstitial spaces, and that's going to lead to edema or swelling in the area. Now we're moving on to the next major category of shock, which is distributive shock. I feel like students tend to have a harder time understanding the concept of distributive shock or come up with examples, but this is the one that is caused by massive vasodilation. So recall that we talked a few slides ago that this when the blood vessel gets a lot bigger, your systemic vascular resistance goes down, and therefore your blood pressure goes down. And again, without enough blood pressure, you're going to lack perfusion. So a very common example of distributive shock is anaphylaxis or anaphylactic shock. We're going to talk more about anaphylaxis in Module 7, but this is a severe allergic reaction where your body releases a lot of chemicals to combat the allergen, and this is causing massive systemic vasodilation and increased capillary permeability. So we highlight that epinephrine is the medication of choice for anaphylaxis, and just recall that epinephrine contains those alpha and beta properties to give vasoconstriction or increase your heart rate. And so it's going to directly counteract the effects of the allergen. Sepsis or septic shock is another type of distributive shock, and this is very similar to anaphylaxis, except instead of reacting to an allergen, it is reacting to a bacterium or virus or even a fungal infection. So again, this is going to lead to vasodilation and increased capillary permeability. And as an EMT, you're going to focus more on managing their airway, their ventilation and oxygenation, but this patient would benefit from IV fluids or medications to constrict the vessels as well as antibiotics. So, we just highlight here that you could consider contacting ALS or, just make sure that your patient makes it to the hospital promptly. So this slide is just a table highlighting the screening tools used to identify sepsis. These have like different criterias or scales that various systems might use to label a patient as in sepsis or not. It is not relevant to this exam, but I leave it here in case you want to review it for the NRMT exam, or if you're just curious about it and you want to take this knowledge with you out into the field. Example of distributive shock is neurogenic shock, and this is caused by any spinal cord injury where our nerves are no longer communicating to your blood vessels to vasoconstrict. So we call this the loss of sympathetic nerve fiber functions, and that's also going to lead to the loss of blood vessel tone. So with that loss of systemic vascular resistance, again, we're keeping into that theme of the blood vessel is vasodilating or nothing is helping it vasoconstrict, and now you are losing systemic vascular resistance and therefore a drop in blood pressure. The next major category of shock is cardiogenic shock, and this is caused by the inability of the heart to contract effectively. So this kind of goes back to our example of inadequate pump function, where you have a heart attack or you have heart failure where the ventricles have failed to pump effectively. And so your stroke volume, your cardiac output is going to go down. And again, if your pump is not moving blood well, then you're going to have hypoperfusion. On this slide, I'm just highlighting how a heart attack is a cause of cardiogenic shock. Remember that if you have damaged heart muscles, it's going to reduce your force of contraction, and therefore you're not going to have as much stroke volume. And if your cardiac output goes down too much, then your blood pressure will also drop. And again, loss of blood pressure, loss of perfusion. Next major category of shock is obstructive shock. And as the slide states, it results from a condition that obstructs forward blood flow. So we have to consider that the volume is adequate, the heart isn't damaged, and the vessels are all of normal size with adequate resistance. Just something is preventing the blood from moving forward. Typically, the causes include a pulmonary embolism, where you have a clot within the pulmonary arteries. Other great examples are like the tension pneumothorax or pericardial tamponade, where we have a pressure either in the pleural space or within the pericardial sac that's compressing on the heart, or the veins leading to the heart, and that's going to cause obstruction of blood flow. And here we have some examples to help illustrate causes of obstructive shock, where you have a pulmonary embolism. There it's blocking the arteries, preventing blood flow. And with the tension pneumothorax, you have a buildup of air in that pleural space surrounding the lungs. And as that pressure increases, it'll also compress on the heart to prevent cardiac output. With the pericardial tamponade, you'll see this blood build up around the pericardial sac that is also going to put pressure on the heart and prevent cardiac output. So, for your exam, you really need to know the examples of obstructive shock, and we'll highlight, the tension pneumothorax and the pericardial tamponade. For the purpose of the exam, y'all don't really need to know too much about the metabolic or respiratory shock. Some sources list this as a fifth category. I think in our class we tend to just identify those issues as what they are. So, for example, if it's carbon monoxide poisoning that interferes with the ability of hemoglobin to carry oxygen, we just call it carbon monoxide poisoning. If you want to review or just kind of keep in mind the fifth category in case the NREMT asks about it, here's the slide. Otherwise, we can just move on. Next, we're going to review the body's response to shock. So if you recall from Module 2, we talked a little bit about the sympathetic nervous system and the release of epinephrine and norepinephrine as two major compensatory mechanisms. First, we're going to talk about direct nerve stimulation. And so this is referring to the sympathetic nervous system, which is pretty immediate in its effect. And we're going to see an increase in heart rate, an increase in the force of contraction. Your blood vessels will constrict, and it's going to stimulate the release of epinephrine and norepinephrine. I know I moved on from the last slide, but I kind of want to touch base on neurogenic shock and just kind of help you all keep in mind that if you have a spinal injury where your nerves are no longer connected to the body and it's not communicating to your blood vessels or your heart, etc., then you're not going to have those typical symptoms that you see with sympathetic response with the increased heart rate or the vessel constriction. And that's kind of the whole point to neurogenic shock is that as you separate that communication, your vessels are going to end up dilating and your heart rate is not going to react to compensate with it. Here on this slide, we're talking about the body's response to shock in reference to hormones. So we said that the sympathetic nervous system will stimulate the release of epinephrine and norepinephrine. And these hormones are going to have effects on the adrenal receptors. If you remember the alpha 1, beta 1, and beta 2. If you forgot about the effects of alpha 1, beta 2, this slide is here for you to kind of just help summarize what they all do. That way you don't have to go back to module 2 to reread this, but I would be very comfortable with the effects of each. Moving on. You definitely need to know how to identify the differences between compensatory shock versus decompensatory shock. And compensatory shock is essentially what it means your body is compensating for whatever is causing the body to lack perfusion. How to tell if your patient is compensating or not, and it's pretty easy. Your patient might have that pale, cool, clammy skin appearance, and that's due to the blood being shunted away from non-vital areas such as the surface of your skin. But what you really should define as compensatory is whether the body is able to maintain a normal blood pressure and therefore perfusion of your vital organs. So it's two main criteria. We look at the blood pressure being above 90 systolic, or if your patient is becoming altered or having, they're losing consciousness, then we're going to say they are not compensating anymore. So if they're no longer compensating, then they are decompensating. And so this means that whatever your compensatory mechanisms are doing, whether it's through an increased heart rate, increased force of contraction, or vessel constriction, none of that is working anymore. And now your blood pressure is starting to drop. So where we said that compensatory shock is when your blood pressure is above 90 systolic and you have a normal mental status. Decompensatory shock is when your blood pressure falls below that threshold of 90 and you start to see signs and symptoms of confusion or in and out of consciousness or they're losing responsiveness. So the biggest takeaway from this slide is you should not rely on any one finding, sign, or symptom. So if a patient just has pale, cool, clammy skin, you can't just say that your patient is in shock. Or if they have a high heart rate, you can't just automatically assume they're in shock. You have to have the whole picture. So you need to have a good history. You need to do a good physical assessment. You got to have, a little bit of common sense to what happened before you were called and then how your patient is currently presenting. And if you can recognize signs of shock, then that's the key to the whole thing because that's when you're going to decide how immediate this transport is, what treatments you can even consider useful, and where this patient needs to go. A key takeaway from this slide is that if you do a thorough history, you might figure out from your sample that your patient takes certain medications. We're going to highlight here that beta blockers and calcium channel blockers can alter the patient's response to shock. So these drugs typically act on the heart where they may lower the heart rate in order to lower and manage the patient's blood pressure. And if the patient has any of these medications in their system, then their body might not be able to compensate as well. So like you might not see typical signs of increased heart rate if they're taking a beta blocker, for example. Here we're talking about the physical exam and the vital role that plays. So again, if they are compensating, their vital signs might look normal. You're going to have maybe a slightly elevated heart rate. You might have a normal blood pressure and your SpO2 will appear fine. But if your patient, I don't know, flew out of the windshield and now they're laying in the street and they're walking around with pale, cool, clammy skin. They got a giant bruise across their abdomen. Um, that's a pretty good sign that your patient is in shock and just simply compensating right now. Also want to have some age considerations. So elderly people, they tend not to compensate well at all. They deteriorate very quickly, whereas children or young adults, they tend to compensate very well, but then when they crash very quickly. And so just, keep these ages in mind and how they influence the development or management of shock. It's a crapshoot either way. So as we wrap up shock, I just kind of want to highlight that shock means, in essence, that your patient is dying. So the whole point of recognizing shock and learning the management of shock is to extend the time of how much your patients have before they eventually meet their demise. And so hopefully you've made it to a hospital in time. Hopefully they've made it to the appropriate centers for surgery or whatever treatment they need to reverse the symptoms of shock or reverse whatever placed them into a state of shock. And if you don't make it, or if, despite all our best efforts, sometimes your patients will expire. And now we go into our talk about resuscitation and cardiac arrest. Um, we're going to define cardiac arrest as when the ventricles of the heart are not contracting, or maybe they are contracting, but the output is not enough, like it's ineffective to where you can't feel a pulse, therefore nothing is being perfused anymore. So here on this slide, we highlight that your brain cells will begin to die within 4 to 6 minutes following a cardiac arrest. And this definition of cardiac arrest, where patients are described as having suffered sudden death within 1 hour of the onset of the signs and symptoms. We often say that the patient goes through 3 phases of cardiac arrest before they lead to biological death, and it's highlighted here as the electrical phase, the circulatory phase, and the metabolic phase. I want to talk more about the electrical phase because this is considered, the first minutes of cardiac arrest, where the heart still has supply of oxygen and glucose, and you still have favorable conditions, and therefore, defibrillation is very important here. So if you witness a cardiac arrest and the patient is in VTAC or VFib, something that is a shockable rhythm, then our AEDs can quickly be attached and we want to defibrillate as soon as possible. And this is going to give us the best chance of resuscitation. Once we go beyond the electrical phase, things get a little bit harder. So now your oxygen stores are depleted, your heart cells are switching to the anaerobic metabolism, and so they're producing all this lactic acid, and you're having the destruction of cells and cell function. So this is where good compressions, high quality CPR comes into effect, and you're going to restore your supply of oxygen and glucose as best you can. And hopefully your patient will still be responsive to defibrillation if they have a shockable rhythm. And again, not as good as the electrical phase, but we're still kind of holding on to hope here that we can resuscitate the patient successfully. When we get to the metabolic phase, which is the last phase of cardiac arrest, this is when things start to look very grim. Um, these take a while, 10 minutes after cardiac arrest, according to the slide. But essentially, your heart muscle is so acidic, so ischemic, that they're dying and they're at the point of no return. And so, once your cell dies, there's no bringing those cells back to life because of the extensive damage that was done due to the buildup of metabolic waste. And here you have your chances of resuscitation are very unfavorable and not very likely. Your patient probably isn't in a shockable rhythm anymore at this point. They're more likely presenting an asystole or even PEA. On this slide, we're talking about withholding resuscitation. So we're kind of recalling those DNR orders, those do not resuscitate orders. Just keep in mind that you have to work your patients unless proof of this DNR order exists, and it has to be signed by the physician and the patient, has to be, within the proper dates. And again, the original copy should be presented on scene for you to withhold resuscitation. Otherwise, you're going to work the patient. Otherwise, if you have injuries incompatible with life, so if the person is stiff and they have been dead for several hours, then we don't necessarily have to work them. Another obvious sign of death is, decapitation. And I always joke with my class, if I ever catch any of you guys doing CPR on the body and ventilating the head that's like several feet away, I'm just gonna pretend I don't even know you. That being said, going back to the beginning, we want to defibrillate our patients early, assuming that they are a workable patient. And the most frequent initial rhythm in sudden cardiac arrest is called ventricular fibrillation. And so that is when your ventricles, they're not necessarily contracting all at once, they're fibrillating. And when we say fibrillating, it's described as like a quiver. And so the most effective treatment for VFib is to defibrillate it. And when you defibrillate, you're sending like a large amount of energy through the heart to basically, hit it as hard as we can in hopes that we can stop all that nonsense. And by stopping that nonsense, we're hoping we can restart a normal functioning rhythm. However, for defibrillation to be successful, we also need very effective CPR. So we want to stop the VFib as soon as possible, but we also need to perform high quality CPR, getting good chest compressions and ventilations in so that we can supply that heart muscle with more oxygen, glucose, and all the good stuff that it needs, as well as removal of waste. This way, the heart is primed and ready so that when you do defibrillate it, it is going to go back to a working rhythm, hopefully. They should all just be kind of reviewing your BLS CPR, but remember to push hard and fast. Your compression should be at a rate of at least 100 a minute, and your compression and ventilation ratio will be 30 to 2. You should try to minimize interruptions or not be off the chest longer than 10 seconds and avoid excessive ventilation. So we can't talk about defibrillation without talking about AEDs. AEDs are in the EMT scope of practice, and they are very useful in that they are safer. Usually you can stay hands off with the AED, as in after you apply the pads and it's time to defibrillate the patient, no one has to touch anything except for the shock button. Um, some argue that it is more efficient monitoring because the manual AEDs require interpretation from a person or a paramedic, and so the AED is not as likely to mess up. Um, I don't know. I always argue that the paramedic is still faster, but they do have a chance of getting things wrong. So the drawback to the AED is it cannot determine if your patient has a pulse or not. So once you slap it on, it's going to analyze the rhythm and it's just going to determine whether it needs to deliver a shock or not. But you, as the rescuer or provider, needs to determine if the patient has a pulse or not and whether CPR should be started and whether you even need an AED to begin with. When the AED is on and it's analyzing the patient, it's looking for VFib or VTAC as its shockable rhythms, and the non-shockable rhythms are asystole and pulseless electrical activity, otherwise known as PEA. While it is analyzing the patient, no one should be touching the patient at all during the analysis stage, and obviously you shouldn't be touching the patient during the shock delivery as well. Any movement will interfere with the rhythm analysis, and then you're going to kind of trick it into thinking it's a rhythm that it's not. The safety risk here is that energy can be transmitted to anyone touching the patient. So we always want to make sure we clear the patient before we analyze and before we shock the patient. Um, I will kind of add on here that once your AED is applied to a patient, even though you get a pulse back or if you've delivered a shock, you never turn the AED off, right? So we're always going to leave the pads attached and keep the AED on for the remainder of that call until you get to the hospital. As a note, we always say that manual defibrillation is preferred for patients that are younger than a year old. Um, we can kind of control the amount of energy being delivered because we can calculate the patient's weight and size. But here on this slide, I just kind of wanted to show the placement of the pads. It's going to be the exact same as you would on an adult. If you're if you're only stuck with adult pads instead of the pediatric pads shown, they kind of still fit in the same vicinity on that top right and the bottom left. But if it doesn't fit, then you just put one on the front and then one on the back. As we're talking about infants, if they have a heart rate that is, I should say, less than 60 with inadequate ventilations, then you need to start CPR. And so if you have the BLS team performing CPR, so if it's a single rescuer, you have 30 to 2 ventilations. But as soon as you have two rescuers or a team is present, then you're going to modify it to 15 to 2. So that's 15 compressions, 2 ventilations if you have more than one rescuer on scene. I don't want to rehash all the details of doing CPR on adults again, but I do want to highlight this last bullet point here that if you are dealing with a pregnant patient, then we have to displace that uterus laterally. So that means that, we're going to just kind of push it over to the side while we do chest compressions. And it's probably better to push it to the patient's left side because we want to get that weight off of the vena cava, that inferior vena cava that's running along the right side of the body. Again, sorry if I'm speaking fast. I'm just trying to wrap this up to stay close to 30 minutes. I know I just went over this in the previous slide, but here it is again for you guys to read it and just kind of digest that information. So when you encounter a patient in cardiac arrest, we don't want to just load and go. You typically want to lay the patient supine and start compression, start CPR. If you have an AED, attach that as soon as you can. If not, then you need to send someone to retrieve it. If ALS is not responding, then you can transport, but only if the patient regains a pulse or if your protocol indicates, you guys have reached a certain point where it's time to load and go. But for most agencies, most protocols, we want to stay on scene and work the patient at least a little bit, whether it's delivery of 3 shocks or work him for at least 10 to 15 minutes before we even think about moving that patient. So assuming you do get ROSC or return of spontaneous circulation, now you got to figure out, well, we got them back. What do we do next? So if we can feel a pulse after the AED indicates that no shock is advised, then it means that you have return of spontaneous circulation. If the patient starts breathing on their own, I don't really like that one because sometimes your patient will have some kind of respiratory response, even though that their heart isn't functioning. And if your patient begins to move again, this has to be more so like your patient is moving, I don't want to say consistently, but more purposefully. When you shock or defibrillate your patients, they tend to do like a sudden jerk, where their hands might like kind of flop up. So that's not the movement you're looking for. You're looking for them to almost be like responsive to the pain type of movement. And here we're just going to go over some special considerations for the AED. Remember that we want to make sure that everyone is clear and not touching the patient during the analysis phase as well as during delivery of a shock. We don't want to defibrillate a patient that is like covered in water or at least like sitting in a pool of water. So we want to dry them off as best we can after removing them. We don't want to, well, we got to be careful about metal surfaces. So just like we said, it can jump from one person to another. Well, we should kind of recognize that metal or metal surfaces are also high conductors of electricity. So, if we can help it, maybe try to move them to a surface that doesn't conduct electricity well or put something underneath them. We want to remove any transdermal medication patches on the chest. And so, like if you have a fentanyl patch or any other medication patch, nicotine patch that's on the chest, you want to get it out the way. And of course, if there's excessive chest hair, then we should shave it off so that we can get better placement with those pads and not burn the patient. I will say a lot of emphasis is placed on the operations of the AED or even the, the progression of CPR in progress. It's one of those calls that gets really hectic in the first few minutes, and it takes a lot of practice, a lot of understanding of what your role is in the cardiac arrest between you and your partner. And so, we want to just kind of nudge you guys to refresh and maintain your skills. You know, talk to your QIC, talk to your partner. Uh, the AHA will make updates every few years or so, and you have to recertify every 2 years. So this is always a helpful thing to just revisit and constantly stay in tune with so that you can always be a deliverer of great CPR. The biggest thing I'm trying to highlight from this slide is the placement of cardiac pacemakers. So like if there's a pacemaker implanted under the patient's skin, you don't want to put the AED pads directly on top of it. We kind of want to just move it off to the side, so we're relatively in the same area that we're supposed to be, but just off to the side and not directly on top of the pacemaker. For those of you that have never seen one, it can kind of look like this, an implanted pacemaker under the skin. And this is just to highlight that besides pacemakers, some patients also have implanted defibrillators, which will work on its own. Again, never put your AED pads directly on top of it. If it's working on its own, then try to let it complete its cycle before you attach your AED. On that note, that's going to wrap up Chapter 15, Shock and Resuscitation. I hope that it'll help you for the exam. And we have 2 more videos to cover respiratory and cardiac emergencies and then the rest.